this is the last talk, but it's kind of the one that I got to leave you with on presbyopia. And we're going to start with understanding the lifetime care of your refractive surgery patient. So the key here is to maintain the patient spectacle-free, come hell, high water, or whatever, rain, snow, or anything. And I want to give you our protocol that we've set up that we think will enable this to happen. And one of the underlying things, which you will see when you look at the PRK lecture, is we're trying to do it without PRK. We're trying to do it without ever going to PRK, for everyone's sake. So you think about the 18-year-old who's been wearing monthly contact lenses, cleaning them herself every night diligently, good girl, with the probability of losing 2 lines of best spectacle corrected vision being accrued every 8 months of her wearing those lenses. Or you can think of that she's wearing monthlies because her parents, you know, they work in a kitchen and they say, well, the monthlies are cheaper, so can we just do. But the rich kid whose mother is an ophthalmologist, she says, no, 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 daily disposables, I'll pay for the difference. And now she's been wearing these contact lenses from the age of 13. Daily disposables, they're safer. And so she's now, let's say 12, because she was responsible when she was 12. And now she's 18, so she's been wearing daily disposables for 6 years. And now she's taken double the risk of losing 2 lines of best spectacle corrected vision than if she'd had laser eye surgery, but she couldn't have laser eye surgery because she was 12. So daily disposables every 3 years accumulates the risk of losing 2 lines of best spectacle corrected vision at 1 in 1,000, which is the same risk as doing LASIK. So she's 18 now, and of course now she can stop taking the risk of poking her eye 14 times a week. And she can immediately go and be assessed for refractive surgery, but of course she has to have an epithelial map. And if the clinic also has an insight, because she's under 21, she's going to have an insight as well. But then she's going to get her corneals procedure. So she's going to get rid of her glasses, and we want to keep that going all the way till she becomes a granny with all of her grandchildren everywhere, depending on whatever lens she's going to have. So we're going to get rid of her glasses with a LASIK procedure, or SMILE. She then is going to have these flaps made up, as we said, 8.2, 90, set M, use S, 55 side cut, right? 55 side cut, which makes ingrowth almost 0 on the primary cases. You have to know how to handle thin flaps, of course. We talked about the side cut, the hinge position. The width is 5. 90 micron flap. She comes back and needs an enhancement, whatever, 10 years later. Now, this first enhancement is probably going to be a flap lift, but it could be a new flap, right? How do we decide between the two? Several factors. We look at the edges of the flap, and if we see a white line, well, there's a white line, that's scarring and fibrosis. That could be a little bit of a traumatic lift that could stretch or tear things and cause ingrowth. And she doesn't live near the clinic? Nah, new flap. But if she still lives near the clinic and her edge looks pristine, you'll just be ready with the 0.12 in case it's a little bit tough, so you can control the eye and not tear anything, and you will lift the flap. So let's say she has a flap lift. Oh, Christ. This is an example of a Hansatone flap that got a little bit of ingrowth, and this is an example of an intralace flap before. Oh, sorry, this information was already on the next slide. So if there's a gutter from this intralace, no flap lift. If there's some ingrowth from that previous whatever, no flap lift. If they cannot attend 1 week, 2 weeks, and 3 weeks, possibly with the washouts, then that determines flap, no flap lift, okay? We talked about the flap lift technique, the specific instrumentation, just a punch through, a specialized spatula to get the rhexis of the epithelium. What will you do if the epithelium is actually ABMD and rubbery? You will, as Glenn showed you earlier, you will recess the epithelium on the host side, and you will make sure that the flap is really nicely tucked in before the epithelium gets to the edge a day or two later. So you'll recess the epithelium, put a bandaged contact lens, and temporarily displace the closure of the wound from the epithelium trying to go over it. And this is the flap lift enhancement, which I think Glenn showed you earlier. Here you are, you know, the technique, boom, 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 boom. That's great. Okay. And so she's made plano again, or plus whatever according to her age factor. Now, creating a new flap is about visualization. We'll talk about this particularly tomorrow in the Smile Day, because we have to know how to make flaps around caps. But here's an example of a previous flap that was, you know, 164 microns up here, about 100 microns here. It was a microkeratome flap. And here's an OCT measuring at all the different levels, all the depths. And that's the flap. And we take the deepest point of that flap and we add 30 microns to get under it, right? So we're going to do a 160 9 millimeter around this 8 millimeter flap, okay? So here it is. Wider, deeper. And now, to reinforce what we said about standardization and always having the same instruments at every time, of course, sometimes you can blow a flap up with one hand, but why do we always have two instruments and a 0.12 ready? Because I'm pushing down here to make sure that I don't go up into the previous interface. And the technique is to push down, go across, get a handshake, and then dissect back towards the hinge using the undissected lower part of the cornea as a pseudo hinge. And you take small bites or big bites according to the resistance that you feel. Quite a lot of resistance. I reduced the bite there. And now I'm going to go for this last strip. And now I'm going to reverse and use the upper hinge as the fulcrum. And now I'm going to separate this, and there we are. Kind of sticky, but I made it look easy, didn't I? I made it look easy because I had the right instruments in the right place at the right time, and I didn't have to futz around with one instrument until I gave up and asked for another instrument. That's why you always come with both instruments, because it's going to be easy, no problem. It's going to be hard, you're already there, okay? So then, here we see it. Here's that edge that was not nice. Here's the beautiful new edge, right? And Bob's your uncle. Here's the old flap. Here's the new flap. I guess it wasn't a hazardome. So again, a non-routine wider, deeper. Primary was 2012, enhancement 2020. Same thing again. Let's go to the lift part. So again, so I'll just go back to piercing, again at always infratemporal. Pushing down so that you're not pushing up and catching the previous stromal component of the previous flap. Punching through, getting a little handshake going. Feel a little metal to metal, pedal to the metal, and taking small bites because I'm feeling a lot of resistance. Using the pseudo hinge technique. And there we are. And now taking the pseudo hinge out. And let's see what happens to that inferior edge. Bit sticky. Again, rotation in order to avulse it properly, like a rhexis, rather than tear it by pushing the instrument through it. Here I am, there we go, got it. Elbow, And here we are, beautiful. Absolutely perfect situation. Looks great.
Is there any reason why they're more sticky, or just happen to be?
They can be, I don't know. Maybe there's been some rearrangement of the stroma because of the previous flap and the previous keratocyte activation, and yeah, who knows. Okay, so that enhancement's done, and now in her, I don't know, late 30s or something, needs another enhancement. So what do? Well, if the flap edge is still unremarkable, we'll lift again. But if not, we'll make a new flap, right? That's if we already did a flap lift. But if we made a new flap, if the flap edge of the new flap is unremarkable, we lift the new flap. If the flap edge is irregular or previous ingrowth, have to go to PRK. So that's like the sort of, what's that called? The booby prize. You have to do PRK. So it's, I don't want to talk about PRK as being terrible, but it is the last resort. So we like PRK because we can do it, but it isn't the first thing we'll do. We're not going to be chickens and keep on doing PRK and torturing the patient when we can do proper LASIK. So this is an example of a second flap, okay? So the target was minus 0.5 in 10. The target in 2021 was minus 1.625, but unfortunately, this patient undercorrected on that enhancement. And that enhancement was done with a second flap. So now I'm going to go back and I'm going to lift the second flap again and dial in more. I'm not going to leave the patient undercorrected because that's not fair. I don't charge the patient for that undercorrection because they don't pay the same every time. They pay a fraction for the enhancement, but I'm not going to charge them again just because they undercorrected. And so we lift that deeper, wider flap again. It's sometimes not easy, again, as you can see. But here, I already have the lower interface, and so I've got to make sure I use the thicker instrument. Not very sticky, but I'm just going to make sure that I'm not picking up any slivers of stroma from the other flap. And I'm inspecting it nicely while I lift it. I'm actually inspecting the lower side, because I want to make sure I didn't separate anything out that causes irregular astigmatism afterwards. So, done that, and now we're on to hyperopia. So primary LASIK, obviously, and we've talked about the flap settings, whether you're a lower than +3, higher than +3, whether your pupil's less or greater than 6.5. M, 8.2. With an 8.2, we can do a 6.7 optical zone. With a 9.1, we can do the whole 7. And if it's less than +3, okay. So we talked about that already. So that gets done at 18. Okay. Now we get to 28, 30, needs an enhancement. Do we lift the flap? Do we make a new flap? Right. So the enhancement decision tree is like this. Look at the primary flap edge. If it's unremarkable, lift. You have an 8.2, 90, 55. Well, that's fine. Lift the 8.2. See them at 1 week. 1 in 20 chance you have to do a washout at the edge and see them in a week. Maybe you have to do another washout and see them in a week. Maybe it's done. Maybe you do 4 washouts and you take them to the OR and put a suture in. That's a 1% chance. But the point is, that's the process. Then you come back and actually, you know what? There was some ingrowth, melt, there's a gutter. So the primary flap diameter is the decider. Because if it was an 8.290, well, you're going to do a new wider, deeper, right? Wider, deeper, 9, 160, 70. So the side cut is not 55. Because if you're cutting that deep, 160, imagine what that's going to look like as a triangle, you know, coming out on the side. It's just way too much triangle. However, if you started with a 9.1, and of course, remember, we do 115s on 9.1s because the edges are better for lifting, then we're going to do an in cut, a side in cut, right? An in cut. So our primary flap was out here, the red one, and we're going to program a 7.8, and the depth is determined by looking at the maximum flap depth and adding 4 standard deviations of the VisuMax, which is 18. And we're going to use a 70-degree angle, okay? 4.5 hinges. So side cut only diameter must be a safe distance from the original. So for example, I believe that you should try and get at least 0.4 millimeters on each side. So it's like a 0.8 less than the original. So the way you can assure this is, I learned this the hard way. When the patient comes into the OR, sit them at the slit lamp first and put little marks. It's a very noisy pen. And you put the little marks at the edge so that when you go to the VisuMax, oh, I actually have a video of that, so that when you go to the VisuMax, you've got a guide as to where this side cut is starting. And what you do is you start the side cut, and your foot is ready to come off. So you start the side cut, and like I was ready like Freddie. Freddie is Tim's son. I was ready like Freddie to get my foot off the pedal. Because if at this moment, right there, off, if I saw that the marks were crossing the marks, I would stop immediately. I'm at 160 microns. No one got hurt. I've cut maybe 10 microns. No big deal. Now I know that this eye is not fitting where I need it to fit. Now I know what I have to do. I come off and I say to the patient, okay, I'm just going to get the centration slightly differently. I want you to look a little bit to the left. No, not that much. I want you to look just like ever so slightly, like 1 degree to the left, and then they look 10 degrees. But the point is, you start manipulating them, and then you see the eye coming back, and then you catch it with the suction and stop it rotating onto the vertex. And now you restart this thing, because you can do restart, and now you're going to do that side cut, and now you're going to get it inside. Okay, so one of the things I learned was that you can't rely on the contact glass 5 years later going on exactly the same place where it went the first time. So you've got to use your marks to do your in cut. Otherwise you'll cross over, and then it becomes lots of fun in the surgery. So let me show you how beautiful this is if you plan it nicely. And of course, these are my LASIK instruments, so I'm actually using this thinner iris spatula type instrument, but I'm lifting the flap practically in the same way. Left hand, right hand. Remember, you've got to force yourself to use both hands. And then it's standard, standard lift technique, 2 instruments, depending on the amount of resistance. Bit tight. Oh, okay. And you just judge that as to whether you're going to do a large or a small bite. Bed is beautiful, edge is beautiful, Bob's your uncle. Okay? So an in cut. Here's an example where I did a LASIK in 2006 with a Hansatome 9.5, and I did an enhancement in 2009 after I got the VisuMax. So you can see that I made a very neat, beautiful little VisuMax flap away from the melted, slightly infolded Hansatome flap. Okay? Side cut only, avoiding that area of ingrowth and scarring. Very nice. Is that this case? I think it is. Okay. There you are. Speed this up. And there you are. Just look. I mean, obviously, Hansatome flaps never stick, right? Watch. Oh, they do stick. All right. Never mind. Anyway, there you go. So, there's the old and the new. Yeah? Side cut only is also used, like I said, when you have areas where there's slight guttering or, very visible or infolded or ingrowth areas of melt. And here you can see the side cut only, real deep, 160 degrees, 60 microns, inside the edge of the flap. There's the edge of the flap just, and I'm inside it. Yeah? There you go. So you've done that enhancement, and of course, they were 18, now they're 30, now they're 38. And you go through the same process. Is the flap edge unremarkable? Lift it again. If not, do a new flap. If you made a new flap, is the flap edge of the new flap unremarkable? Lift it. If the flap edge is irregular or previous ingrowth, you have to do PRK. Okay. So, and if you did a side cut, by the way, inside, it's the same thing. Can you lift that in cut again, or do you have to do PRK? Right. Now they've got, they need another enhancement because now they're presbyopic and they need presbyond, right? And it's the same logic as to what you're going to do, depending on whether you can create a new flap, lift that flap, which one is clean, which one is not clean, well, or go to PRK. Nothing wrong with PRK. It's a very good procedure, but not as good as overnight healing. So here's an actual patient, like an actual patient, okay? The primary was an 8.290. At 45, came back for presbyond enhancement, only tolerated -1. So that was done with a new flap, deeper, wider, after that. Came back 10 years later, needed to improve the reading again, -1 not enough, boosts up to, probably regressed slightly, needed more boosting. Enhancement 2, flap lift of the 9.1. This patient then shows up when they're 70, they haven't done this yet, but when they're 77, they show up, and then I look at the spherical aberration on the cornea, and I select an IOL that will help us with that, and we take out the natural lens and put the plastic one in, and this is vision for life. Okay, so that's an example of how you keep the patient in your practice and all of their referral network, and then their children, because by the time they're 45 or 50, they're starting to send their children to you. So this is how you build a practice, yeah? Looking after your patients, not discharging them. Example number 2, 48th, I'm going to get my eyes done, 2010, right eye was, both eyes were -2, 8/100. Okay, 2010, these protocols were not solidified yet. We had just had the VisuMax for a couple of years. So, yeah, some of these historical ones are not exactly the same. But by 2012, unfortunately, the right eye hypermetropicized. Left eye stayed fine and didn't require any more treatment. So, we did a primary flap lift on the right eye and treated the +1. The right eye stayed plano, but 2015, now the left eye hypermetropicized. Okay, so we did a new flap on this side, probably for reasons that I mentioned earlier, targeted -175 because I'm thinking, well, these eyes are hypermetropicizing, so I'm going to buy her more runway by going a little more than -150. And I explained that to her. 8.8, 150, deeper. Yikes, she comes back 4 years later. Now both eyes have hypermetropicized further. Now, of course, you could say that if I'd done a clear lens exchange on her at 48 for a -2, well, you could say that, but the myopes are the least happy ones if they're young, especially the low myopes. You could say that I should have done that when she was 52 or 58 or whatever, but the fact is her cornea still had a 30% chance of changing by 1 diopter anyway every 5 years. See, that data has been published, right? Corneal stability has been published by multiple sources. These tend to be optometric schools that are interested in these kinds of things. Refractive surgeons do a clear lens exchange and discharge the patient, never see him again. They have no concept of what happens to the refraction of the eye over time. So we need to go to the literature to know what's going to happen to refraction over time. So now she came back hypermetropicized again, and now I made a new flap in the right eye, and I lifted the wider, deeper flap of the left eye. I targeted 175. And here they are, all the flaps. So you can see the original flap here, the new one here. So I lifted this one. And here, as you see, the one that I had lifted, and then the new one that I made this time. Okay? All very neat. And one day, we'll probably do her lens. Probably. But, you know, there's an example of a myope who, unfortunately, hypermetropicizes, but she can be kept out of glasses. Constantly, no problem, at very low risk, and very quick visual recovery. So we come to this question about lens and cornea. And so you see, even you can get caught out like this. Here's a patient with 3 bloody enhancements. And you could say, well, should have done lens. It's like, okay. But does that mean you just do lens surgery and you don't do any? No, because most of the patients don't end up with 3 enhancements over a period of 15 years. Most of them don't. So how do you go ahead and decide between the two? Well, the answer is, well, the real question is, what is the most common presbyopic procedure offered to patients? And the answer is, it's clear lens exchange. That's the most commonly offered procedure. LASIK and monovision is less common in the population. Amongst eye surgeons, it's the other way around. But in the population, it's less common because surgeons tell them that. Now, why is that? It's because of social engineering. There's a lot of social engineering that goes on in our profession, which is why we formed the World College of Refractive Surgery. We needed an objective body that stops companies from bullshitting medical personnel into hyperbole about, you know, marketing-driven stuff that is short-lived, short-term investment stuff, saying that the lens doesn't have any night vision disturbances like the Symphony, and then it does. You know, that kind of stuff. We're not being regulated properly here. If the airline industry was so poorly regulated, there'd be airplanes falling out of the sky every month. So the social engineering we see is that from the year 2000, when the multifocals started coming out, like the Array, the thing is that around the same time, phaco started getting better. So I learned phaco in the 1990s when to be a good phaco surgeon, you had to have a really fast foot and you had to have really well-developed, you know, like extensors of your ankle and really fast coordination, because when the chamber went like this, you had to like come off. Now you young ones here, you have no idea how lucky you are, because you put that thing in, and it doesn't matter what, the chamber stays maintained. That thing can be leaking, it could be spraying in your face, and it is still going to maintain the anterior chamber. So, okay, so when that started, these computerized fluidics, phaco got a lot safer. And so the confluence of increased safety in phaco with the availability of the promise of perfect vision at all distances, like the Array lens was promised to give everyone, that confluence led to an impressive marketing drive at the ASCRS, AAO, and ESCRS. It was, I remember the ESCRS in Stockholm, like I told you, when Howard Fine was presenting the Array lens, the horrific Array lens, which was pulled from the market. No one would put that thing in it. But he was saying it's the best thing in the world. There's going to be no more LASIK. 22-year-old -1s are going to have clear lens exchange with a multifocal. I'm telling you, if there's a recording of that, I love it. But I remember it. I was sitting there, I was in shock to hear that. Anyway, the good thing that the lens community did, and they still do, and the brilliant thing that the lens community does, is that they under-promise and over-deliver. So most lens surgeons say you'll still need readers. Expect it. +1s here and there, dim lighting, you know, small print, for reading prolonged times. Even the most confident clear lens exchangers will tell that to the patients. They under-promise. And then when they get a lot of spectacle independence, they're heroes, right? So that was a good thing that lens surgeons did. The bad thing that corneal surgeons did is that they did the opposite. They overpromised and underdelivered with this Vizix crazy-ass profile. So they were like, yeah, we're going to be able to do it on the cornea. It's going to be amazing. Blah, blah, blah. It's like, that cornea looks really bad. You know, and all this intracore and now supracore. And you know, intracore is ectasia. Okay? Just wait long enough. So sadly, the corneal presbyopic camp went multifocal, and they overpromised and underdelivered. Then you have things like like I said, the meetings continuously pouring, you know, lighter fluid on the fire about how wonderful it is and how you are not one of the gang if you're not putting in diffractive IOLs. Like, if you're not putting in diffractive IOLs, you're nobody, okay? See, those people are somebody. They put in multifocals. You're nobody because you're not putting them in. And they make you feel like that. I leave the meetings thinking, well, maybe I should be putting these things in. You know, because they make you feel bad. Because it looks like, yeah, everyone's happy. The patients are happy. The patients are happy. The patients are happy. The patients are happy. There's very little science and statistics on that. You look at the literature, there's very little on cumulative vision. There's 9 graphs are practically non-existent on clear lens exchange. They always do mean vision, which totally hides the fact that they have 60% 20/20, like in the Aufhart study, yeah, Kretz and Aufhart, right? 60% 20/20 with the trifocal. Now, okay, maybe they're crap, maybe it's 80%, but it's not 95% up to -8, or in plano presbyopes, 95%. So the social engineering around us it's a lot of noise. So let me bring that to the impact on our practice, okay? So if we look at 2010 to 2017, when we did this analysis, 56% of our patients are over the age of 40. More than half. We do more presbyon than we do regular refractive surgery on young people. And the distribution is that for most of the hyperopes are presbyon patients, obviously. Some of these are high hyperopes in their 30s. Half of the myopic treatments we do are presbyon, and some mixed cylinder. Obviously, all of the emmetropes are presbyon, right? The thing about this graph is that emmetropia piece of the pie should be something like 70% of our caseload. But the problem is that emmetropes who get presbyopia, they go to the optician, and the optician says, laser can't fix it, you need to buy some readers for me. And then they prescribe these readers that are plus 125 minus a quarter in the right eye, and plus 125 in the left. They go, it's customized to each eye. When they could have gone onto Amazon and just bought plus 125s. But, you know, and then they say, oh, it changed a little bit. So the next year, they prescribe plus 125 minus a half, and here, let's go plus 150 minus a half, yeah, customized. So we have this lack of information from the public, and they are being cannibalized and they are being misled by the optometric industry, who lie through their teeth, and I don't mind saying it publicly, because I have a list of all of the things of patients coming in. Oh, no, no, you can't have laser. Why? Because you have astigmatism. It's like, I'm sorry, we're in 2022. We've been correcting astigmatism since 1993. That's before your parents poured the wine to make you. So we have a problem, guys. That's why the World College of Refractive Surgery is going to include optometry, because we consider optometrists to be part of refractive surgery, not outside of it. They are eye care professionals, and they should have the skills to be involved in what is refractive surgery, because they also have the skills in contact lenses and glasses. And there's nothing wrong with glasses, nothing wrong with contact lenses, But please don't say there's something wrong with LASIK, because there isn't. It's a wonderful procedure that's been performed in 60 million times already around the world. It's not an experiment, okay? You're not some kind of trailblazer by having LASIK, okay? It's old. So that is the impact. And if you look at just the distribution of PRESBYOND in our practice, 45% of it is myopes, 45% of it hyperopes, and only 10% are emmetropes because they didn't know they can be done, even though that's the biggest group out there. We only have 30% of the British population wearing glasses. So 30% have distance problems. The other 70% are emmetropes in this country. So as you can see, we almost do PRESBYOND on everyone, minus the 2% who aren't candidates. Not everyone's a candidate. Remember I said to you, 97% of the people who walk through the door are candidates. But it's pretty much a given that we will do PRESBYOND if they are a candidate. So how do we go lens or cornea? Well, we have been using the HD analyzer. This device has an ocular scatter index. That ocular scatter index is way more objective than these images, which can be made to look like anything, and way more objective than the LOX classification, which is all over the place in terms of repeatability, inter-observer repeatability. There is also the eye trace, which has a dysfunctional lens index, and it'll do the same thing. It uses a very similar principle, a double pass principle of looking at scatter. And so based on OSI, as you can see, our LBV patients, which are in solid, we will do it, well, this is before Joaquin Fernandez published this paper, but if it's a 1 or 1.2, we'll do PRESBYOND. We knew that above 1.5 is where we really should be treating with the lens. So you can see that our distribution, and this is without asking him, he just published that paper, that's what we were doing. We were kind of going to lens if the OSI was a bit high. And that's the beautiful thing, is that the OSI is an objective test. And you can show it to the patient, it makes sense to them. Some of them don't want intraocular. It's like, I don't want anything in my eye. It's like, yeah, but the thing is, do you see? Your lens isn't in the green anymore, it's in the yellow. You can leave it, but it's not appropriate to do what your friend got with the PRESBYOND. But we can get you a great outcome, etc., etc. So remember that you can get some of these high values just because the refractive error is high, the cylinder is high, or the tear film isn't great. So some of these people that we did PRESBYOND on, they would have been a pre-op measurement taking it at the first visit, and they had a poor tear film, and then we fixed their tear film, and then we did their surgery, but we didn't repeat the OSI. Obviously, we wouldn't operate on someone LASIK if they had an OSI of 4 from a tear film. But you can see that we're doing PRESBYOND in patients over the age of 50, which is where we're told you can't do LASIK anymore. Actually, over 55, actually over 60, actually over 65, actually over 70, actually over 75 if they have a low OSI and good contrast. Why blame the lens for something that it's not, doing wrong, okay? You're not restoring accommodation. You're replacing it with a lens that splits light and is substituting the functionality. You're not improving the function of the lens by replacing it. So, obviously our cataracts, we don't do that much cataract surgery, but as you can see, once we started measuring OSI, they're all over the place because that's called a cataract. By the way, my father, who passed away in January at the age of 89, which is, he did a good job. I did his PRESBYOND when he was 74. He was 20/16 in both eyes, best corrected, and had normal contrast. And he was plus 175 minus 125 in each eye with an oblique sill. And I was examining him as I would once a year, and it was Thursday evening, and he was 74, so that would have been, whenever, 2007. No, yeah, 2007. And he said, so what's the deal? Do you think you can you fix it? I was like, I never operated on a family member, obviously, I'm like, well, and we'd done about a year, year or two of Presbyon. It wasn't commercially available. It was Tim programming it manually in the Waska, putting the spherical aberration in, cheating the machine, backdoor, like totally off-label. And I was like, you know what, Dad? Actually, yes, I think we can. He said, well, when can we do it? I said, well, the only way we're going to do it is if we do it at 8 o'clock tomorrow morning, because I don't want to have the weekend to think about it. And he said, fine with me. So we showed up at 8 o'clock in the morning on Friday morning. And, it was a bit freaky, right? Because I hadn't done this before. I mean, I'd done 7,000, 8,000 LASIK procedures, and I had a Hansetome. But I was like, gosh, this is a bit weird. And then I thought, no, it's not. It's an eye. I'm really good at this. Just focus on the problem. And I got in there, and I did it. It was totally routine, automatic pilot, effortless mastery, as it's called. And he was amazing. And he was totally spectacle-free. I did an enhancement for him when he was 79, 5 years later. And he came back at 85 with a bit of cataract. So we did one of the cataracts. We were going to do the other one, but his Parkinson's started to get bad. And so one thing led to the other, and we never did the other eye because he went in from having good vision to not, and it was a bit variable. But he was basically spectacle-free from the age of 74, thanks to this protocol of starting on the cornea and then going to the lens. 70-year-old female that I presented earlier, OSI was still good 12 years later, right? And she had those macular changes. So there was no way we were going to do laser on her. And she still had reasonable lenses, even though she's 70 years old. So it's like, obviously, we're going to do a retreatment on your cornea because there's good reason to not do lens surgery on you. Okay, so these parallel universes that we talked about, what is the most common presbyopic procedure chosen by surgeons? Well, this shouldn't be there yet, but Fernand de Wilde came up to me at ACOS in June of that year, 2019, and said, I'm very frustrated with I'm plano presbyon, I'm really frustrated, I liked your talk, would you let me come to London, and I want you to do a presbyon on me. I said, well, could you wait until November and have the surgery, that was the first one, have the surgery a couple of days before the course, and then you'll give a talk about your decision process and whatever. And he's a very active cataract surgeon, does clear lens exchange with multifocals. Rob Morris was the medical director of Optegra UK, and he came with the sub-director in the north of England, James Ball, and the now medical director, Amir Hamid. They came to our very first course after that. Actually, he was there. So they watched him talk about his experience after we'd done the 8-hour jackhammer treatment that we've given you today about the science of presbyopia. And after jackhammering this whole thing down and then hearing de Wilde's story, Rob Morris came to me and said, wow, that was really impressive. I've got a bunch of clear lens exchanges booked for next Wednesday, and I frankly don't feel like doing them anymore. And by the way, the other thing is I'm a -5, I'm 62. Would you do my presbyon? I was like, sure. So we waited until the next course and did his for the next course, and then he presented the ESCRS, and so on, and so on, and so on, and so on. And so Cecile was online on our one of our previous online courses, and she said, well, I've had presbyon also here in France. I had my colleague do it. They're like, oh, so can I capture your picture? I said, smile, and I captured the picture, but this needs to go down in the bottom. Anyway, all of these surgeons have come through the course, pretty much, and I've got a playlist. We had a PRESBYOND user meeting, September 2020, I think it was, and I asked a number of you who are in the room and lots of other people to record a 3-minute, either a chat or a presentation on why you decided to implement presbyon in your practice, or how's it going, or how difficult was it, or how easy was it, or why did you have it on your own eyes, or whatever, but 3 minutes. And I'll send that playlist out through Tim. It's on a YouTube channel. It's unclassified, so it's not public. But you can. They all gave permission for us to show this to other eye surgeons. And I'd like you to look at those 23-minute videos at some point, because it's very interesting to see how your colleagues have done when they've changed their way of practice from one to the other. And so it brings us to the slides from some of their presentations. So Fernand comes back and says, I'm basically not doing RLE for myopia anymore at all. I am doing, I'm not comfortable doing more than plus 350. Okay, fine, so he's doing LBV up to that, but he's still doing some RLE. But in fact, he told me recently that his RLE, this line has come down, so he's doing more hyperopes because he's becoming more confident with that. Christian de Courtin in Switzerland, very old friend of mine, shows that his multifocal IOL rates, he was, in Switzerland there's not a lot of multifocal IOLs because the insurance system doesn't pay for it, and the Swiss are kind of cheap and they want to use their insurance, and he only gets 250 francs to do a cataract, and it's all very complicated. But he was a heavy hitter and did like 80 patients a year or something. That's a heavy hitter in Switzerland for multifocals back then. And he was an early adopter. And he was the darling of Alcon, actually, because he was putting these things in a lot. And he was doing cataract surgery, but he also did multifocals. So his conversion rate was, what is that, 15%, 10%. But he introduced blended vision, PRESBYOND, in 2010. And in the first year of introducing PRESBYOND, he did 5 times the number of presbyopes than he had done the year before with clear lens exchange and multifocal. That's because it's easier, as he said, it's easier to convince a surgeon, I'm just going to do LASIK and you'll be able to see at distance and near, than to tell them that you have to take the natural lens out and this and that and the halos around the light in the night and you'll get used to it after 6 months. So he found it easier to convert patients to LBV, and so that LBV volume went up and up and up and up and up and up. And his multifocal went down and down and down to 0 practically, except when he came to London to the ESCRS, and Alcon promised that the Symphony doesn't cause night vision disturbances and is an EDOF lens, and he put a few in, and then he stopped, but his partner continued to put it in for another year, and then he stopped. So they basically do cataract surgery or PRESBYOND. They don't really put multifocals in anymore. They do one or the other. Andrea Russo can talk about his own slide, but if you look here, this is from our PRESBYOND club, which you're all currently qualified to apply for. It's a very exclusive club, and it's called the PRESBYOND Club, and we meet once a month. It's a Facebook club, and we have a 2-hour grand rounds. Bring your case, ask some questions. We'll often have a guest speaker. We had Andrea Russo as a guest speaker. Where is he? He's not here.
He went back to his room.
He went back to his room. Okay. So he used to do 22% RLE in his practice, and once he introduced PRESBYOND, he ended up doing 27% PRESBYOND, and let me see, yeah, no RLE. And this guy, a quarter of his income came from RLE, and then it went to 0. And he tells me that this is growing. So of course, he still does cataract surgery. We have 307 members. Barbara at the back, she is the medical director of Optegra Poland, and I think she came to the course the first time about 2018 or something, or 17, and she came back a couple of times, and she has trained and sort of infused the knowledge into Poland, and they have 13 clinics, I believe, in Poland, and they're doing exceedingly well, as you can see. Their RLE rates were pretty good, right? But they're going down and down and down and down, and their PRESBYOND rates are going up. This is from when she presented once for us. So that's her. And then we have Andre. He's here. Are you here? He's there. This is amazing. So that, remember, well, you weren't here when I told the story about why you charge more for PRESBYOND than clear lens exchange, which I love. I love that. Because it's better. It's a pretty simple answer. If you'd asked me, I'd probably talk about it for an hour. He just said, because it's better. It's like, but his PRESBYOND rates, you know, going up, clear lens exchange rates going down. Same story with Federico Alonso in Spain. PRESBYOND surgeries up, price of PRESBYOND up, and you know, it's a very successful introduction. The proportion of corneal surgeries with PRESBYOND has increased by 25% when he presented this. So we know from this user meeting, and like I say, I've got this playlist of these 20 speakers. At that time, there were these 20 success stories or stories, let's say, of different kinds from all over the world. And Sri Ganesh was in there, of course. We have a clinic in China, very happy PRESBYOND patient and surgeon from Mexico, or two in Argentina, someone from Peru. So, you know, this is it. So we go back to this question, what is the most common presbyopic procedure chosen by surgeons for their own eyes? And I challenge anyone to tell me that it's not either LASIK monovision or PRESBYOND. But it certainly isn't clear lens exchange with a multifocal, because we know that the uptake rate for ophthalmologists is exceedingly low for multifocals. So I'll leave you with this slide that we started with, which is that PRESBYOND is a system. And this system is one where, if you understand, it's very easy once you get it. We've given you a massive amount of information today, but it's all recorded. This entire day has been recorded, and it will be available online, so you can review it again. And we welcome you to come back in November. We'll repeat the course in November. It may not be 4 days live. It may be just Saturday, Sunday live. We might do hybrid, where we do these lectures for everyone to watch before the Saturday and Sunday, which will be purely Q&A, expert level 2 stuff. Yeah? Because I think we're getting to the point where we can go and make the courses level 2, so we can talk even more about the depth complexities, you know, the difficult cases, rather than going through all this basic stuff. But here's what's interesting. We have been doing, and I think a number of you have been doing, SMILE in the middle of the PRESBYOND system, right? So in other words, you've got your PRESBYOND system, which is the counseling, the acceptance test, the anisotropia, the titrating, the counseling, the informed consent, the management, the temporary glasses post-op, all of that stuff that we talked about. And instead of LASIK PRESBYOND, you just substitute and do SMILE, right? Guess what? You think the results are the same? Better? Worse? Same, better, worse. Same, better, worse. Same, better, worse. What do you think? Worse? I got a worse. I got a same. Anybody else? Going. Another worse? Another worse. The worses are up. Come on. We got 2 worses versus 1 same. Sold to the whatever. Okay. Here's what's interesting. It's better and worse. Here's what's interesting. The refractive control is better. So the percentage eyes within a half diopter of intended sill and sphere is higher with SMILE. Doesn't surprise you, right? There's more variables in LASIK. Humidity, blah, 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 blah. All that crap is gone with SMILE. That's the beautiful thing about SMILE. There's so few variables. But the visions aren't as good. In other words, they don't have the depth of field. So they have more intermediate complaints, and they don't have the range. They don't have the plus 150 test. They don't see as far. You know, generally it's 20/60 with a nascent cornea, with a virgin cornea, and it's about 20/50 or 20/40 sometimes plus 150 test after PRESBYOND. These patients are still 20/60 on the plus 150 test. They don't have the same depth of field. So we're looking at this rather informally at the moment with quick and dirty analysis. But we're actually, because we have such a huge PRESBYOND database, and we've now done, I think, quite a few SMILE procedures this way, we're going to be able to really match control. And perhaps by November, Tim, you promised? No. Okay. We'll make him promise. By November, we'll do a matched control data set, and we'll be able to show the difference. And that's because we're not controlling spherical aberration the same way. SMILE is way too good at not increasing spherical aberration, which is why we say it's a great procedure, because it doesn't increase spherical aberration that much. Well, it's not good for PRESBYOND, because below -4, it doesn't increase spherical aberration. In fact, it even decreases it in some eyes. So it's not a good, you can't just do SMILE monovision and expect the same efficacy. You can expect the same accuracy or better, but you can't get the same efficacy out of SMILE monovision. So we'll still do it if someone has a bit of a dry eye, because you gotta, you can't, right? You gotta do what you gotta do. But we don't expect the same depth of field and not necessarily the blend. What's happening next is that we are in the process of developing a way of doing SMILE PRESBYOND, but it's very complicated, I have to say, because trying to induce spherical aberration in a -3 treatment, is not. The profiles have to be aspheric in a very different way.
Yeah, but if you treat a high myope with SMILE, you really use quite.
So if you're treating above about a -6 or 7, the induction of spherical aberration is okay. But if you're treating below that, it's just not enough. It's not enough. It's really monovision. Okay? So we've had a wonderful, exhausting day. It's 7:20. We're running just about an hour late. But hey, was it worth it?
Yeah.
Okay, thank you.